especially in Taipei City, is still 20%, but in 1984 and 1991, all of these study subjects have not received any kind of vaccine, but you can see that there's already declined. It means that use of disposable syringe and also to prevent this iatrogenic infection is also very important to control hepatitis B infection in Taiwan. And after we have this immunization program, I will go through that data, but this just show you that the reported cases of acute hepatitis B in Taiwan and from 1993 to 2019, and basically the number are quite small, and especially in this period of time, after year 2000, the number is less than 10. And now I would like to go through the seroprevalence of hepatitis C virus infection in Taiwan. And as you can see, this is the paper, the first paper on hepatitis C published by DS, by Professor Chen and this study group. And they found that among the volunteer blood donor, the anti-HCV positivity was around 1 to 2%. And for those who have elevated ALT, the blood donors, its anti-HCV percentage was 10%. So at that time, before this discovery of the hepatitis C virus in 1989, before then, Taiwan Blood Bank used this elevated ALT to screen out the anti-HCV infection. And among the sex workers, you can see this anti-HCV positivity is around 3.5%, not very high compared to this volunteer blood donor. But intravenous drug user and also the hemophiliacs, and they have a very high anti-HCV infection. And so we try to elaborate the risk factors of hepatitis C virus infection in Taiwan, and this including just a blood transfusion, have a relative risk around 9-fold, hemodialysis at 5-fold risk, and also acupuncture and medical injection, tattooing, also the surgical operation. So you can see here that basically in Taiwan, most of the HCV infection are through the iatrogenic infection or through this drug abuse. And you can see here, there's a very wide geographical variation in the seroprevalence of hepatitis C infection among adults in Taiwan. And as you can see, the instance, the prevalence may be as low as 1.6 or 1.7% in Ma Gong and Gaosu, but it can be as high as 10, 11% and 20% in Shanzi and Baisha. So basically, you can see a very wide variation in this anti-HCV seropositivity. And the reason for that, we found that most in this area, there's an iatrogenic infection through non-disposable syringe and medical injection. And the instance is quite parallel to this prevalence of anti-HCV positivity. And in Taiwan, we try to control hepatitis C viral infection through this use of the disposable needle and syringe, screening of HCV in blood bank, and also have a good health education. Of course, we also have antiviral treatment program since that's reimbursed by National Health Insurance since 2003. I'm going to go through that data. And with regard to the reported cases acute hepatitis C in Taiwan reported by Taiwan CDC, and you can see there's the number for each week at basically not so high, but sometimes there's an outbreak here. And also in year 2017 and 18, we found that there's an increased number of acute hepatitis C, and the reason for that is drug abuse. So drug abuse is a very important risk factor for HCV infection. So we try our best to monitor this HCV infection among these groups. And with regard to the seroprevalence of hepatitis D virus infection among the surface antigen seropositive, and as you can see here, among the volunteer donors, the anti-HDV infection is around 2%, And for the general population, for the general population in the community is 2.7%, and sexually transmitted disease patient as 8%, and sex workers and intravenous drug abusers at much higher anti-HDV infection. And in order to control the hepatitis D virus infection, we used disposable needle and syringe screening. Sorry, that's the HDV in blood bank, and also the control through HBV infection. Of course, we can try to control HDV infection through the HBV immunization. And as you can see here, that's from 1993 to 2019, there's the reported case of acute HDV in Taiwan. Basically, not so many. There's one case or two in different weeks. They are quite scarce, so it's not so prevalent now. And this may be due to contributed by this hepatitis B immunization in Taiwan. It's very successful, and more than 90% of the infants got this immunized of HBV vaccine. So maybe this is one of the major reasons for this decline in acute HDV infection. And with regard to this hepatitis E virus infection, according to different studies in different periods, and as you can see that anti-HEV infection is lower in Taipei City. In Kaohsiung here, Aboriginal area is even lower than this non-Aboriginal area. This is quite confusing to us. This is carried out by Dr. Pan in 1995, and in year 2004, there's a different area study, and in urban central Taiwan is 3%, rural central Taiwan is 3.7%, and Aboriginal central Taiwan is almost the same. So I consider that this, to control this hepatitis E virus infection, the most important is through this water and food sanitation, just as the same as this control of hepatitis A virus in Taiwan. But you can see here, the reported case of acute hepatitis E in Taiwan from 1993 to 2019 basically are not so many in Taiwan. So the most important viral hepatitis infection in Taiwan is hepatitis B and hepatitis C. Now I'm going to talk on this liver cancer control in Taiwan. This is a map for the global liver cancer incidence. As you can see that liver high incidence area is in Southeastern Asia and also the Mongolia and also this sub-Saharan Africa. And the liver cancer was the seventh commonly diagnosed cancer and the second common cause of cancer deaths in the world. That's published by Global Can in 2012. And in 2015, there were around 554,000 new liver cancer cases and 810,000 deaths from liver cancer in the world. But before the identification of hepatitis B virus and hepatitis C virus, basically we can do very little to control liver cancer. And fortunately, Dr. Bloomberg identified the hepatitis B virus in 1964, and he also developed this its diagnostic test and also this vaccine. So I think it's a very important contribution to eliminate this hepatitis B in the world and also save millions of lives in the world. And nowadays, we all know that this is this endemic area for the hepatitis, for the liver cancer, the Southeast Asia and Sub-Saharan Africa. But if you look at the seroprevalence of anti-HCV and also the seroprevalence hepatitis B surface antigen, and this geographical distribution basically are quite consistent. The higher the anti-HCV prevalence or higher the HBsAg seroprevalence, the higher the instance of liver cancer. So now we all agree that HBV and HCV are the major etiological factors for liver cancer in the world. However, the importance of HBV and HCV and alcohol basically varied in different countries. For instance, in Japan, That's HCV is more important, it's around 80%, and HBV is 15%, alcohol 10%, and others is around 5%. And in other area, especially in Southeast Asia, and including this China, Taiwan, and Mongolia, and you can see that HBV is important, around 70%, HCV 20, alcohol 10, and others 10. And in Europe and North America, and you can see HCV are more important than HBV and alcohol. So the most important thing is that we have to check this longitudinal trend. What kind of liver cancer secondary to etiological factors are related, increasing. And this is a comparison for global deaths from liver cancer in 1990 and 2015. And as you can see that from 1990 to 2015, there's around 60% increase in liver cancer. And the increase mostly attributable to hepatitis B infection. This is a 51% increase for the liver cancer secondary to hepatitis B, and this is a 390% increase for hepatitis C related to liver cancer. And liver cancer secondary to alcohol use, basically, there's a decline. And also for other liver cancer, such as aflatoxin-induced liver cancer, also declined around 20%. So the most important thing is to control hepatitis B and hepatitis C. And I would like to come back to this story in Taiwan. And the very first case control study on HBV and HCC in Taiwan is carried out by Dr. Miriam Tong of UCLA. And he carried out a very interesting study of 55 HCC cases from Taipei Veteran General Hospital and 943 soldiers in this Joyin naval base, and he found that surface antigen seropositivity was 80% for the cases and 15% for the control, showing a relative risk around 23-fold. But this kind of cross-sectional case control study cannot elucidate this causal temporality. So Dr. Palmer Beasley carried out a GECC, government employee clinic and cohort study to check this surface antigen seropositivity and HCC risk. And in his GECC study, including this 23,707 cases, that's around 3,400 surface antigen positive and 19,000 surface antigen negative. And after this 5 years of follow-up, you can see the mortality from primary hepatocellular carcinoma per 100,000 was 1,158 for surface antigen positive, and surface antigen negative is only 5. And that's showing a relative risk as high as over 200-fold. So at that time, we consider that indeed there's a causality between the hepatitis B infection and this HCC. But more importantly, we found that since this HBV is important, can we do anything to stop this HBV infection? And Palmer Beasley and also there's colleagues in National Taiwan University Hospital carry out a case control study. And also, you can see here that the vaccine efficacy is as high as 94%. For this placebo group, control group, after this 12 months, there's around 90% of the newborn will become surface antigen positive. But for this, the treated group with hepatitis B immunoglobulin and vaccine is only 4%. So you can see that efficacy is very high. And fortunately, we have a very strong viral hepatitis control group committee in our cabinet at that time. At that time was chaired by that Professor Song Ruilo, and Professor Chen Dingxin was also in the committee. And they implemented the nationwide immunization. And in the first 2 years, only newborns of surface antigen carrier mothers were immunized, and then all newborns were immunized by 1991, we used the recombinant vaccine. And in Taiwan, the immunization program is unique for that we screen in pregnant women first, and for the surface antigen negative children and infant will receive vaccine at birth, 1 month and 6 months years old. And surface antigen positive, we also test a mother. If mother were surface antigen positive, we also test for E antigen seropositivity. And for E antigen seropositive mother, then we will give this an infant HBIG in addition to vaccine. So, and let's look at this coverage. The coverage in 1984 to 1986, this coverage is only for surface antigen positive, baby born to surface antigen positive mother. It's quite high as well. It's around 89%. And then after that, you can see our immunization coverage basically are quite satisfactory, or over 90%. And you can see the hepatitis B surface antigen seroprevalence in children and young adults in Taipei City from 1984, that's before the immunization program. It's for all these age groups, it's around 10% and to 14%. But after the immunization, there's a decline in hepatitis B surface antigen seroprevalence from 9.8% to 0.6% in 20 years. And vaccine coverage rate, I just mentioned that for the infants in Taipei City was as high as 97%. And more importantly, we have to see whether this kind of immunization have efficacy and also the effectiveness to control this human hepatitis. The very first publication was published by Dr. Gao Jiahong, and he documented that infant human hepatitis mortality declined a lot after the implementation of this hepatitis B immunization program. But these slides by Zhang Junru in JAMA year 2013 is a follow-up analysis, and you can see that the age, sex-adjusted rate ratio for infant fulminant hepatitis mortality, if this is an immunized cohort born in 77 to 80, and then you can see all the way down by 2009 to 2011, and there's a sex-adjusted rate ratio of infant fulminant hepatitis mortality already become 0.03. It means that more than 95% of the fulminant hepatitis has been controlled. And more importantly, Dr. Zhang Meihui published a paper in NEJM in 1997, and he found that there's a reduced instance of liver cancer in immunized boy and girl aged 6 to 9 years. And you can see here that an immunized birth cohort have instance of 0.52 per 100,000, and for immunized children, it's only 0.13, so around a 75% reduction among the immunized. And a follow-up analysis published in 2017, and you can see that for this unimmunized birth cohort males, and this is immunized birth cohort, and this is for female unimmunized, and this is immunized. You can see for all the age group from 5 to 9 to 20 to 29, there's a very significant difference. So you can see the age-sex adjusted rate ratio declined around 80%. So immunization by hepatitis B indeed is very successful to reduce the liver cancer risk among the vaccinees. However, there's some vaccine failure. So Dr. Jian Yingqi, he analyzed the data collected by CDC. This is for 3.8 million vaccinees, and to see what's the reason for this vaccine failure. And I won't go through the detail of this chart, but I will show you that if we look at this cumulative HCC instance of the vaccinees by maternal serostatus of surface antigen, this antigen positive mother are more likely to develop HCC among the immunized children. And also, incomplete immunization has a higher cumulative HCC instance than an immunized one. So, in the future, I think the most important challenges to HBV immunization program is that for surface antigen seropositive a baby born to surface antigen seropositive mother, maybe we can try to use this antiviral therapy during the third trimester. And HBV immunoglobulin, we have to give it within the 4 hours rather than 24 hours after birth. And of course, we have to have a complete HBV vaccination on schedule. And we all know that immunization is a magnet for solidarity that transcends borders and sectors. And fortunately, hepatitis B vaccine has been included in national immunization program of 184 countries by now. Unfortunately, that's worldwide, 84% of countries have this hepatitis B immunization program, but only 39% provide the necessary birth dose, the dose at birth to prevent hepatitis B. But not everyone who can be, liver cancer can be controlled through the immunization, especially for those who already become this chronic carrier. So we have to know there's a natural history of CHB. And in the natural history of CHB, there's a seroclearance of E antigen and also the seroclearance of HBV DNA and seroclearance of surface antigen. And the seroclearance of these three milestone biomarkers basically will reduce the risk of HCC. And as you can see here from our review of HBV study, the lifelong risk of cirrhosis for men is around 43%, and for women is 29%. For HCC, for men is around 25%, and for women is only 9%. Why? Why there's a difference? Can we predict the risk of this hepatitis B surface antigen positive to see who have at a higher risk to develop the HCC? So this is a paper we published in year 2002, and you can see here that's a E antigen. Seropositivity of hepatitis B E antigen is associated with an increased risk of HCC compared with E antigen negative carriers. So from this chart, you can see that compared with surface antigen negative, surface antigen positive, E antigen negative have a relative risk around 10-fold. But both positive ones have a relative risk of 60-fold. So hepatitis B E antigen serostatus is important. And in year 2006, we found that this the higher the viral load of HBV DNA at the study entry, and the higher the risk of HCC. And furthermore, we also found that there's an genotype C HBV infection has an increased risk compared to genotype B HBV infection. And in addition to that, we recently, sorry, there's something wrong with the slides, but this is high and this is low. And the serum HBsAg level at the study entry was also important. And the higher the serum HBsAg level, and the higher the risk of HCC. So there's so many HCC risk predictors for chronic hepatitis B patients. This including the viral factors and also the host characteristic and viral exposures. So can we combine all these risk predictors together in order to give us a very easy to use risk calculators? And indeed, we developed several risk calculators, and this is just one of it published by Li Meishuan. And you can see in these models, we include there's an age, sex, a family history of hepatocellular carcinoma, serum ALT level, hepatitis B E antigen serostatus, surface HBV DNA, surface antigen level, and HBV genotype. For instance, for a man aged 50 to 59 and no family history with an elevated ALT with an E antigen negative and very high HBV DNA level, and also there's a very and at any level of hepatitis B surface antigen and with this genotype infection of B or B plus C, and have a different risk score. And with some of this risk score is 14, so from this nomogram. And if the patient have a risk score of 14, and there's 5 years risk, 10 years risk, and 15 year risk is around 4 to 5, 10 to 20, and 30 to 40. And you can see there's an AURC for different prediction duration. They are all more than 85%, sorry, 85%. However, this kind of risk calculator has to be internationally validated by other study cohort. So we developed this RICH-B study scheme, and we use our reviewer HBV cohort to develop this RICH-B risk score and validated by hospital-based composite international cohort from Chinese University and Hong Kong, Yonsei University, and also the University of Hong Kong. And as you can see that in this RICH-B risk calculators, and we also use this gender, age, ALT, HBeAg, and HBV DNA to derive this RICH-B risk score, and we give this SCC risk at 3, 5, and 10 years on this slide. I won't go through the details, but you can see from these slides that the overall validation set, the AURC is around 80, but for that non-serotic validation set, is for 3 years is 90 AURC, and 5 years and 10 years is around 80. And also, this the predicted SCC risk and observed SCC risk basically are on the same line. So, in other words, this RICH-B is international validated. So, we have to use this modern technology to try to educate the people using these SCC risk calculators. And these are some of the risk calculators on the website. And in addition to HBV related SCC, we also studied HCV related SCC calculators, and they are on the APP2. But more importantly, if we know that there's a long-term risk of SCC, then we have to try to help these chronic infected people. And of course, this is the data published by Professor Liao Yingfan. They found that antiviral therapy can reduce the risk of SCC very effectively. And also, this is the data published by Dr. Mindy Yoon's group. And they found that there's a U.S. treated group and there's a reviewer and U.S. non-treated group have very striking difference in SCC risk after adjustment for RICH-B score, and there's an adjusted hazard ratio is around 0.23, around 75% of this SCC can be prevented by antiviral treatment. So, in Taiwan, in year 2003, just after the SARS outbreak, DS Chen came to see me. I was working at this Department of Health. Then we started our antiviral therapy, and you can see at the very beginning, we are quite cautiously and give a very stringent criteria for the antiviral therapy. But after then, we expand our antiviral therapy program in Taiwan. And I just want to show you the data of reduced SCC incidence and mortality after the launch of hepatitis B therapy program. In year 2000 to 2003, we haven't implemented any kind of antiviral therapy, and showing this an adjusted relative risk of 1. And in year 2016 and 17, it's already down to 0.56 for SCC mortality, around 40% reduction, and for SCC incidence, it's around 35% reduction. In other words, our antiviral therapy program is quite successful. However, we consider that we need to implement a nationwide screening program, and then we have to use a longer treatment for antiviral therapy against chronic hepatitis B. And with regard to this ineligible patient at increased SCC risk, we have to do this early diagnosis. And fortunately, since 2017, also urged by DS Chen, said, CJ, we have to use DAA to control hepatitis C in Taiwan. And we implemented the very first phase is in January 24th, 2007. At that time, we used a high-risk use DAA for high-risk patients only. But recently, our Prime Minister, Su Tseng in the cabinet, he said that we are going to expand our DAA treatment, our HCV in Taiwan. As you can see, in 2017, we used around 3.1 billion NT dollars to treat around 10,000 people. Of course, the SVR rate is also very high, always very high. In 2018, we spent around 5 billion, and 2019 is around 7 billion. And in the coming years, from 2020 to 2025, each year we are going to use 8 billion NT dollars to treat around 50,000 patients. So we hope that we can expand our program by strengthening this nationwide screening program, relax this treatment eligibility criteria to reach WHO 2030 goal by 2025. And just now, Dr. Wu Mingxian said, CJ, we definitely can do it because all the gastroenterologists here, all the hepatologists here are so enthusiastically to control HCV in Taiwan. So we all know that viral hepatitis elimination target set by World Health Organization by 2030 is to have a 90% reduction in new case of chronic HBV and HCV infection and 65% reduction in deaths from chronic HBV and HCV through different kind of strategies, different targets, including the immunization, and also there's a prevention of mother-to-children transmission of HBV, blood safety, injection safety, as well as harm reduction and the diagnosis, and also the treatment of HBV, HCV. And WHO set up a goal that by 2030, we have to have 80% of eligible HBV and HCV patients are treated. And now we try our best to push forward, and we hope that by 2025, we can reach this WHO goal. With that, I would like to urge us, all of us, to work together to promote global health. And thank you very much for your attention. Thank you.
Thank you, Professor Chen, for the comprehensive review of our fights against viral hepatitis and liver cancer in Taiwan. I tell you that the true people who is behind the scene is he. He's the one who is pushing everything. And each time, many of us went to him. Well, because usually the keynote lecture do not take questions, okay? But unfortunately, because of security, he cannot be reached after the lecture. But maybe you have questions, you can send it to me. I can forward that to him, okay? With this, I think the organization, I want to send you a plaque of appreciation. Jesus.
He has been an internationally recognized leader in HCV research in the areas of biology, pathology, including the hepatocarcinogenesis. He directs the NIH Collaboration Center for Human Immunology in HCV and is the co-PI of the Harvard HBV Consortium of the NIH HBV research work. He's the PI of the MGHGI, the Regime T32 training ground, and hold multiple NIH R1 grant and the NIH K24 mentorship award. He recently co-chaired the AGA WSLD Academic Skill Works in 2018 and the WSLD ESO Special Conference on HCV elimination in 2019. And he also 18 as associate editor of hepatology, gastroenterology, and journal of infectious disease. I think everyone know him very well. He's an international well-known scholarship. So today we are very proud to have him to deliver the keynote lecture entitled "Remaining Challenges of HCV in the Post-DAA Era." So ladies and gentlemen, please join me to welcome Professor Raymond Chuang.
Thank you very much, Professor Yu, and to all of the organizers for this outstanding meeting. I'm genuinely honored and thrilled to be here, and certainly as well to speak to you on the topic of hepatitis C virus, where we stand in the aftermath of the revolution that has been really initiated by the introduction of direct-acting antiviral therapy. There are still remaining challenges, but as you will, I think, hopefully learn from this talk, there are still even more opportunities, I think, that are afforded by the introduction of these extraordinary treatments. So I'll start by just indicating my disclosures and really give you an overview of what I'd like to cover in the talk today. We'll first cover the benefits, the immediate clinical benefits, and there are already early returns on that in the DAA era. I want to talk about the implementation of the elimination agenda, the design of a broadly protective vaccine. These remain, I think, the major challenges in the post-DAA era. There are certainly DAA non-responsive populations, but as we'll talk about, they're relatively rare. And because HCV is a liver disease rather than just simply an infection, we do know that there remains remnant liver disease and remnant risk of that liver disease for complications, including, and perhaps most importantly, the risk for HCC. So there are reduced but not eliminated rates of HCC in those with advanced fibrosis. And we'll explore a little bit about why that risk persists in these patients despite cure, and how do we stratify for that persistent risk. But I do want to cover, I think, a novel set of opportunities that have been introduced by the introduction of DAAs, and that is the notion of transplanting organs from HCV-infected persons into not just infected recipients, but uninfected organ recipients as well. And we've certainly kicked this practice off in the United States. I want to share with you some of the early experience with that. So the early returns in terms of sustained response and associations with benefit. We know that there are benefits to sustained response based on the interferon era. Yes, interferon, that archaic medicine that we once used commonly for our patients with hep C, was in fact, despite its difficulty, associated with clinical benefit. And these are data certainly from a number of this is one of several cohorts that have demonstrated the point that patients with advanced fibrosis, in this case bridging fibrosis or worse, who are treated with interferon and achieved sustained response, achieved remarkable improvements in both liver-related mortality and reductions in referral for transplantation, but also improvements in all-cause mortality, shown here on the left panel, as well as improvements in hepatocellular carcinoma compared to those patients who failed to achieve sustained response. And this was after a follow-up period of about 8.5 years or so. So the benefits were actually quite clear in terms of at least interferon-based therapy. But with the introduction of direct-acting antivirals and the combination of these direct-acting antivirals to produce extraordinary cure rates, as seen with this pan-genotypic regimen of sofosbuvir and velpatasvir, the question was now, could we in fact see corresponding clinical benefits in patients who achieve cure using this much more acceptable and well-tolerated route of treatment? And the answer is the immediate effect, I think, was best and graphically demonstrated by those patients who had decompensated cirrhosis and were treated with these regimens. Well, first of all, the very idea that we could treat these patients was revolutionary because interferon-based therapies, as you might recall, were contraindicated because they actually hasten the decline of hepatic function in these decompensated patients. Instead, patients who receive direct-acting antiviral regimens, like, for instance, a phospholipid combined with ribavirin, in patients with child class B or C cirrhosis, were associated with remarkable rates of sustained response in the neighborhood of 85 to 90% rates of sustained response with as little as 12 weeks of therapy in child class B and child class C cirrhotics. And if that weren't enough, what we also saw correspondingly was an improvement in clinical status. So you'll see here on the left panel that these are MELD scores relative to the baseline. So anything below 0 here reflects improvements in MELD scores. Anything above 0 reflects worsening of MELD scores. And you can see here that the significant majority of patients, about 2/3 to 3/4 of these patients, experienced improvement in their MELD scores with successful sustained response, indicating not just clinical stabilization, but even improvement in clinical status in most of these patients. And this was reinforced by the concept that albumin levels improved in these patients, whether you were in child class B or child class C, or regardless of the duration of treatment that you received. So this was clear-cut evidence that clinical improvements were possible with successful elimination by direct-acting antiviral therapy, immediate clinical benefits. But now that DAAs have been around for about 5 to 6 years, we've now had the chance to even learn that there are benefits for those patients who weren't quite so sick. So this was a study from the US Veterans Administration, about 100,000 or so patients who had hepatitis C as represented here. This was essentially fairly controlled hep C with FIB-4 scores less than 3.25, suggesting that they did not have cirrhotic disease. About 40,000 of these patients were treated with DAAs and had, again, an excellent sustained response rate of about 97%. Now, if you look at the mortality rates, there was a significant reduction in those persons who had SVR, 1.18 deaths per 100 person years, compared to those who either didn't have SVR, 2.84 deaths, or those who were untreated, 3.84 deaths in the same time context. So the multivariate analysis of this data set revealed that the hazard ratio for sustained response for mortality was 0.44, or better than 50% reductions in mortality for sustained responders compared to non-sustained responders. And so there's a clear-cut sense, even in the patients who don't have cirrhotic HCV disease, that we are improving overall outcomes, even with the follow-up that we're describing, the brief follow-up that we're describing in this study. Separate studies have also demonstrated improvements in renal outcomes. We know that hep C is associated with extrahepatic manifestations, including cryoglobulinemia, and we have seen improvements in GFR as well as improvements in cryoglobulinemia. This is an example of a data set from a group treated at our institution. 13 patients who had type 2 cryoglobulinemia in association with chronic hepatitis C infection. And these were patients treated, again, with DAAs. And what we found here was that the sustained response rate among this group of 13 patients was very good. It was 85%. But perhaps, just as importantly, what we saw here was a marked reduction in proteinuria, as well as improvements in glomerular filtration rate in these patients, immediately in conjunction with successful clearance of viremia. So again, with extrahepatic manifestations, we are seeing clear-cut improvements in clinical status. So these are some of the immediate dividends of DAA-based therapy. So the challenges now that we've solved the science of hepatitis C, that is to say, been able to essentially achieve cure in nearly 100% of patients, is really to achieve what we just heard about in Dr. Chen's talk, which is essentially to talk about achieving those World Health Organization benchmarks. 90% reductions in incident hepatitis C infection and 2/3 reductions in mortality by the year 2030. And it turns out that where there's a will, there's a way. And so we already have seen, based on projections, that there are a number of countries that have made the commitment to these targets that are on track statistically to achieve those benchmarks. They include many countries in Western Europe, UK, France, Spain, Switzerland, as well as Iceland and Australia, among others. And the commonality to these countries is that they have single-payer systems, and therefore, with the governmental will, there is the ability to transmit that will into action. However, unfortunately, most countries are not on track, and that's certainly true of the United States, where we have a fragmented insurance system and payers who still, to this day, exercise restrictions on approving these DAA regimens. The other, of course, really important area, I think, has to be case identification, the maximization of screening. And this is an area where, again, in the United States, we have made some measures work, but we are far from complete in our penetration in terms of case identification. I will say that there's been encouragement in that our agency that supports essentially screening recommendations, the United States Preventive Services Task Force, has just in the last month made a recommendation to not just take baby boomers, who are named basically adults born between 1945 and 1965, from where most of the HCV epidemic resides, but an acknowledgement of the fact that there are many cases of incident HCV among our very young patients. They've made the recommendation to screen all U.S. adults, at least on a one-time basis. And I think this will go a much greater way, I think, towards identifying new cases of hepatitis C. But regardless, once the diagnosis has been made, there has been ample demonstration that those patients are simply just lost in the cascade that follows. That care cascade results in very low rates of ultimately of SVR among those diagnosed. So we need to link those patients to care and to therapy, particularly in areas where the hep C epidemic resides, in those patients with substance use disturbances, and to link essentially those patients in care for SUD to treatment for hepatitis C. So care and treatment, diagnosis and treatment should be linked intimately, as well as implementation of harm reduction, particularly the dispensation of clean syringes to injection drug users, where most of the epidemic is actually being transmitted in the United States. So this is just essentially a map of essentially how countries are doing globally in terms of achievement of targets. Those who are in red are not on track. Those who are working towards include Taiwan as well as the United States and others. And the elite few in green are those who would appear to be on track for achievement of the World Health Organization goals. So the other, I think, measures that could be used to facilitate and enhance our ability to achieve ready treatment, particularly in those in low and middle income countries, would be the implementation, because of the ease of treatment with DAAs, of minimal monitoring regimens. And so this would involve something along the lines of prescribing a full course of DAAs, dispensing them to the patient, and essentially drawing no bloods and having the patient return not back to the clinic until they are done at SVR 12 time point, and then obtaining a blood draw at that point and confirming and documenting cure. There will be occasional phone calls, but under a protocol known as the AIDS Clinical Trials Group A5360 trial, which is actually a multinational study. There is exactly this, a 12-week regimen of sofosbuvir valproatic being recommended for patients essentially with minimal monitoring. And we hope that this actually will catalyze much more ready treatment of individuals in less resource-intensive locations. Another interesting potential role would be that for taking a page from the HIV therapeutic playbook, which is to say the use of long-acting sustained release regimens. In HIV, we've seen advances in long-acting agents, integrase inhibitors like cabotegravir combined with rilpivirine, combined to essentially allow once monthly or less frequent dosing than that. And so this may actually have utility for patients who are transient populations, who have limited adherence, active injection drug users, persons in institutions who are incarcerated, where much, again, of the epidemic is concentrated. This may, again, represent another approach to dealing with that group of patients. But let me be clear that if we're going to eliminate hep C from this planet as a pathogen, it is important to be reminded of the fact that no infectious disease of humans has ever been eradicated without a successful vaccine. So the elimination targets are not eradication targets, but rather functional elimination, right? So the challenge for true eradication would be the development of vaccine, which we do not have yet, of course, for hep C. And the challenges are there's genetic diversity, weak neutralizing antibody responses, but recently there was the development of a vaccine that was based on a chimpanzee adenovirus vector, which harbored a non-structural region of the HCV protein, which was given as a prime, followed by a boost with a modified vaccinia virus that actually proved to be quite immunogenic in volunteers. So recently, after many years of a randomized controlled trial among injection drug users in the United States, over 500 such IDUs were randomized. The data were just analyzed, and unfortunately, this vaccine failed to protect these individuals against incident hepatitis C infection. So we're back to the drawing board, unfortunately. And so other approaches that are now in early phases of study include purification of viral antigens to make multi-antigen cocktails for vaccines, as well as the administration of stronger adjuvants in conjunction with these vaccines. But this, again, continues to remain a challenge moving forward. What about non-responsive populations? So non-responsive is a relative term, right? Because we're talking about lower relative responses to DAA regimens. And so there are a number of subtypes that have been described among the 6 major genotypes that may have diminished responses. In Africa, for instance, genotype 4R, 1L and 1P have been associated with diminished response rates to ledipasvir and sofosbuvir. So it's important to note that there are pockets of the world where these subtypes may be associated with diminished responses. Decompensated cirrhosis, we just described, 85 to 90% sustained response rates, again, owing perhaps to the lack of ability to perfuse a fibrotic cirrhotic liver with adequate concentrations of antivirals. And patients with hepatocellular carcinoma, Dr. You talked about this yesterday, reduced rates of sustained response described in 89% versus 93% in a large meta-analysis of 49 studies. Moreover, if you looked at those patients with HCC, those who had active HCC had a diminished response rate versus those who were treated, who had inactive HCC, 87% versus 93%. So these are modest decreases in response, but suggest that we should perhaps sequence our treatments adequately in terms of managing the HCC first before treating the Hep C. Fortunately, though, the addition of a third class of therapy, in this case a protease inhibitor, added to an NS5A and a polymerase inhibitor, such as sofosbuvir, velpatasvir, and voxeloprevir, has done an excellent job in salvaging patients who have failed DAA regimens. So better than 95% rates of sustained response in these DAA failures, including sofosbuvir, velpatasvir, and glucapavir, pibrenizumab failures. So for those with HCC then, let's consider treating the Hep C after we've controlled the HCC. And for those with advanced decompensated disease, like the child B and C patients, consider treatment, at least in those liver transplant candidates, after transplantation has been performed. Next slide. Oh, here we go. So what about the issue of HCCs developing in patients who have been treated with DAAs? So there was an initial alarm sounded a number of years back in Europe where cases of recurrent HCC in persons who had already been managed for primary HCC, recurrent HCC was described following a course of curative DAA therapy for their Hep C. In one series from Spain, which triggered all this, 27% of HCCs were described as being recurrent within the first 6 months after SVR with 8 DAAs. Another study suggested a difference in the quality of these recurrent HCCs. They were multinodular and infiltrative in about half of cases. And so this triggered a lot of alarm, a lot of concern in the community, and a lot of studies to try to replicate that. And so many such studies have been reported, and they consistently have found that they do not suggest a recurrence or occurrence risk in excess of rates observed with prior interferon-based therapies for hepatitis C. In fact, one meta-analysis of 40-plus studies in nearly 14,000 patients showed no difference after adjustment for study follow-up and age, essentially showing that there was in fact, there was perhaps a reduced risk of about 0.68 for occurrence and a reduced risk for recurrence. So there was no evidence to suggest that excess risks of recurrence or occurrence were taking place. In the US, a VA study of over 84,000 patients who were treated with DAAs found that the hazard ratio for HCC development was reduced by about 70% for sustained responders compared to no sustained responders. So the clear-cut, I think, clinical evidence is that there is benefit to treating patients in terms of reducing future risk of HCC, whether occurrent or recurrent risk of HCC. However, and this is a study conducted by our group in conjunction with another VA cohort, essentially of 18,000 patients who were either treated with interferon previously, about 3,000 such patients, DAAs in another 5,800 treated patients, and then about 8,000 untreated patients. And what one can see here is that on the left two panels, that if you compare the interferons in the orange and the DAAs in the blue, that there was a higher frequency, there was older age, higher frequency of cirrhosis and a higher frequency of diabetes, risk factors for HCC in patients in the DAA cohort. This was an aging and a worsening medically of the cohort compared to the interferon era. They were a sicker group of patients. They had a better rate of sustained response, certainly not surprisingly, with DAAs. And when you look at those cirrhotic patients who were treated, and you look at sustained responders in the middle, not folks who failed to achieve sustained response, there was no excess risk of HCC in those patients receiving DAA-based regimens compared to interferon-based regimens. And untreated patients shown here on the right had again, high rates of HCC, certainly in excess to those seen with who had achieved sustained response. So there again, we saw no evidence of excess risk of HCC in the context of receipt of DAAs in a US veterans cohort. So it appears then that rates of HCC described perhaps in those early studies are related to baseline risk factors like cirrhosis, Child-Pugh status, age, diabetes, and thrombocytopenia, and don't deliver or differ from interferon-related reductions after adjustment. Nonetheless, though, they do raise the question as to are we, in these recurrent cases, losing immune surveillance with these DAAs? In other words, with these early HCCs, are they becoming unmasked in the context of receipt of DAAs? Regardless of what the facts are, surveillance for HCC remains essential for those patients at risk, bridging fibrotics and cirrhotics, even after SVR with DAAs. I think that's become an absolutely clear mandate that these patients must be followed. And the further studies required to determine when we can back off on screening or surveillance for these patients. A recent paper in Gastro suggests that risk is still present over 10 years after a sustained response. So we may not be done ever surveying patients for HCC who started off with risk factors in terms of bridging fibrosis and cirrhosis. And these are just data just showing that this is actually a heat map of interferon-stimulated genes in patients with hep C, shown here on the far left at baseline. Red indicates high expression of these interferon-stimulated genes. And with each week of treatment with DAA shown in subsequent panels, we see that many, if not most of those interferon-stimulated genes wither or recede, right? And so one of the questions may be that the loss of these ISGs or ISG expression in these patients could in fact promote loss of control in the sense that they may be contributing to some tumor control, at least in the context of understanding why that may have happened in the original descriptions of HCC. That's food for thought. But why the residual risk for HCV? That's the question. Why the residual risk of HCC in patients with chronic hep C? We know that unlike hep B, this is not a virus with latency that does not have a stable form in the nucleus, does not integrate into the host genome. There's no insertional mutagenesis taking place with hep C. But instead, there are genetic changes that could result from hep C infection chronically. And they include genotoxic stresses, DNA-damaging stresses like oxidative stress that result from chronic inflammation. We also know that viral proteins induce proliferative and anti-apoptotic signaling factors, including receptor tyrosine kinases, and inhibition of TGF-beta, Wnt signaling, induction of EGF and EGF signaling, and inhibition of P53, among others. And so these can all collectively contribute to growth and proliferation and loss of apoptosis. There are also viral proteins from hep C that alter signaling circuits of differentiation and angiogenesis, like the Notch signaling pathway involved in differentiation and VEGF involved in angiogenesis. So all of these could be affected by chronic infection with hepatitis C, and those derangements could remain or persist long after the infection has been eliminated. But so too can there be epigenetic changes, changes in the chromatin that regulate the transcription of gene sequences. So too are there also cofactors that may reside in patients long after HCV cure. And these include, of course, steatosis in the form of fatty liver, alcohol and alcohol consumption, iron excess, and hepatitis B co-infection, to name several, as well as microbial translocation that can also be seen in patients with advanced fibrosis. So with epigenetics, the question is, are there scars that persist to drive altered transcriptional programs even after removal of the virus infection? So, generally speaking, we think of chromatin as regulating the accessibility of DNA to transcription factors. And there can be modifications of chromatin, including methylation, that restrict that access, and acetylation of those histones that actually enhance that access, that are permissive for transcription. So it's possible then that viral cure does not reverse these HCV-induced epigenetic changes. And this is certainly a testable hypothesis in that those modifications of histones that are induced during infection don't fully revert back after infection has been cured. And these transcriptional changes then persist and contribute to HCC development long after cure of infection. So this was a study conducted by Tom Baumert and colleagues in France, which basically took biopsies of patients with a variety of conditions, including Hep C, Hep B, NASH, and treated patients, DAA-treated patients with hepatitis C as well, and essentially did what's called chromatin immunoprecipitation, which essentially identified specifically modified chromatin, which is modified at a position called H3K27, which is essentially a histone modification that is permissive. It is an enhancer for transcription. So this H3K27AC is a mark for enhanced transcription, enhanced access to transcription. So by bringing down H3K27AC with the immunoprecipitation and then sequencing the RNAs associated with that, we could get a sense of that state of enhancement of transcription. And that was described in this particular heat map shown here, where all the groups here are aligned. The HCV infected are shown here in the red, uninfected in the green, DA cured in the orange, HBV infected in the pink, and NASH in purple. And you can see here, just generally speaking, with looking at this heat map, again, of what we call CHIP RNA-seq, you can see here that HCV infected differs from, say, HBV and NASH infected. They have different patterns. But when you look a little bit more closely within HCV infected, those patients with advanced stages of fibrosis, shown here, tended to have a more enhanced degree of epigenetic modifications, shown in the right panel compared to the left, with the darker marks indicating enhancement compared to the lighter marks. Moreover, when you looked at those who were DAA cured, those patients who had earlier liver disease, so F2 and F3 shown here, actually showed modifications and partial reversals of these changes compared to those patients who were, again, chronically infected. And those patients, however, who had advanced disease, in this case F4 disease, failed to revert those modifications that were seen in the chronic infection state. So these changes did not appear to revert compared to those changes seen in those with earlier stages of fibrosis. So these data suggest then that there are persistent epigenetic changes, particularly in those patients with more advanced fibrosis and those patients who we might even view as being at enhanced risk for HCC. When one looked at all these populations, those who were cured in either the limited or more advanced fibrotic stages or those who were chronically infected, and you looked at the genes that were modified by these histone marks, one could find here a number of these so-called driver genes that are involved in growth and de-differentiation of cancer. And these include cyclin-dependent kinases shown here, as well as members of the EGF pathway. Moreover, a second study, an independent study that we participated in along with Professor Yu, indicated that again, this was a similar study of ChIP-seq looking at a different epigenetic mark known as H3K9AC. essentially found that there was an 8-gene signature associated with these marks that could reliably predict a risk of HCC. And in these persons, when you looked at 7 biopsies of patients with hep C, you found that 6 of these 8 genes were up. And these genes actually, these marks persisted in those patients who achieved sustained response with DAAs, suggesting again that those marks did not disappear or revert with successful clearance of virus. Moreover, it appeared that those marks in tissue culture could in fact be reverted by the use of a histone acetylase inhibitor called C646, or by an EGF receptor inhibitor known as erlotinib. So these were modifiable if you could change the epigenetic modification itself. So these suggest potentially a role in the future for epigenetic modification to try to reduce future risk of HCC. So chronic HCV induces specific epigenetic changes associated with liver disease progression and carcinogenesis that seem to persist post-cure. And the persistence appeared most pronounced in those patients with more advanced fibrosis compared to more moderate fibrosis. And they appear to result in persistent transcriptional changes of HCC risk and of specific driver genes after cure. So we now have the opportunity to potentially identify these epigenetic changes as new markers for risk and to reverse these changes. So the next question then is, what tools can we use to stratify those at future risk of HCC now that we've cured their infection? So one way to do that would be to try to identify perhaps a gene signature from these patients to say, are they at risk for hepatocellular carcinoma? So these are actually data derived from a collaborator named Eugen Hashida, who's formerly at Mount Sinai, now at UT Southwestern in Dallas. Essentially, where he started by looking at patients who had undergone resection for HCC and then asked who subsequently developed future HCCs, and in fact death. And he identified, using an agnostic approach, using, again, gene arrays, he identified 186 genes in a signature, including some poor prognostic genes, shown here on the left, including EGF, and some good prognostic genes. So overexpression of the poor prognostic genes and underexpression of the good prognostic genes were associated with the worst prognosis in terms of future risk for HCC recurrence and death. Right? And so this so-called 186 gene signature, which he called the prognostic liver signature, was then subsequently associated with HCV fibrosis progression and indeed HCV clinical outcomes. And so he showed here that the prognostic liver signatures actually can be induced by hep C infection in vitro. So this is tissue culture data shown here on the right, showing that HCV induces the high-risk genes and suppresses the low-risk genes in comparison to uninfected, to lack of infection. So again, getting to this notion that HCV infection itself is responsible for driving that prognostic signature. And moreover, when you look at patients with other etiologies of liver disease, so these are tissues from patients with not just C, but hep B, alcohol, fatty liver, and a combination thereof, they too exhibited the same pattern. That is to say, their HCC recurrence risk tracked along with the expression of these gene signatures. The higher risk gene signatures in terms of a high risk for recurrence were upregulated, the lower risk gene signatures were downregulated, and vice versa in those who had low future risk. So this appears to be a pan-etiologic signature, not just hep C, but also found in other conditions. So one might very well imagine that the co-expression of hep B or of fatty liver disease or alcohol further compound the risk of this signature being adverse. And interestingly, if you then looked at those patients who were treated with antiviral therapies, in this case, these were antiviral therapies based on interferon, but I think the concept is still the same with DAAs. And that is that if you looked at patients, these were paired liver biopsies, in patients who had hep C, in about 30 such patients, what one saw here was that those patients who subsequently went on to get HCC, shown here in the first and the third panels, suppressed their high-risk genes less impressively than did those patients who did not go on to develop HCC, and moreover enhanced their low-risk genes less impressively than those patients who did not go on to develop HCC. So there is an incomplete reversal of the poor prognostic signature in these patients who achieved sustained response. So again, consistent with the idea that there is a persistence of risk, genetically, epigenetically, and transcriptionally in these patients. So how do we put this into practice? This is a biopsy-based signature. It's dependent on liver tissue, and we're moving away from liver sampling from our patients as a whole. So we need a non-invasive alternative. And so efforts are underway to try to identify secreted proteins that correspond to these genes and create a kind of a secretome, if you will, that we can capture in a blood test. There's also the notion of looking at a liquid signature, so either using cell-free DNA, which unfortunately does not really correspond to any signature DNA mutations, so maybe not less useful in this context. MicroRNAs are highly stable in circulation, but they may not have a clear-cut, there may not be a clear-cut microRNA signature that has been identified. Exosomes shed by both normal and disease cells may be, I think, an interesting a way of pursuing this opportunity to sample these signatures in the circulation. And circulating epithelial cells, or CTCs, CECs, may also be a direct window into circulating hepatocyte cells or hepatocyte-derived cells, and then simply looking at those and their signatures to see if they match the signatures within the liver. So these represent opportunities for translating these findings into clinical practice. So what to do about these once we find them? Well, it turns out that there are approaches to potentially try to modulate risk. And this is what I would characterize as being chemopreventive. We can't transplant every cirrhotic patient who gets cancer. We don't have enough organs to do that. But here there are potentially approaches using currently available medications that might help, statins and aspirin being two of them. So we and others have done a number of population studies that have demonstrated quite clearly that statins and aspirin are associated with decreased risk of HCC in those populations. Lipophilic statins, we just published a study in the Annals of Internal Medicine that showed that lipophilic, but not hydrophilic statins, are associated with adjusted hazard ratios of about half in patients with hepatitis C, and with the maximum benefit shown in those who received over 600 cumulative defined daily doses of the statin. And these are lipophilic statins like atorvastatin or simvastatin. So too, aspirin, given at 1.5 standard doses per week or more for a period of over 5 years, also associated with an adjusted hazard ratio of under 0.5. And this was shown in patients with HCC due to any etiology of chronic liver disease. And it turns out that both aspirin and statins, at least in vitro, can help modulate that prognostic liver signature that I just described to you. So there is a theoretical basis for thinking potentially about the use of these types of commonly available agents potentially for reducing future risk of hepatocellular carcinoma. So I talked about challenges, but there are some novel opportunities that have been introduced by the availability of DAAs. And I think the one in our country that has been particularly poignant has been the opportunity to use HCV-infected donor organs in uninfected recipients. There's an increased demand with a worsening of donor organ shortage, and clearly a corresponding increase in donor supply of HCV-infected organs because of the opioid overdose epidemic in the US, with lots of overdose deaths in young people who are also HCV-infected. We've seen, obviously, with well-tolerated curative therapy, we can administer these therapies preemptively or certainly reactively with pan-genotypic regimens with few or no drug-drug interactions in transplant patients. And there is a precedent for treating donor-derived infections. Certainly in the case of CMV, we do this all the time, as well as anti-core positive donor organs for hepatitis B, which are transplanted safely with concomitant administration of indefinite antivirals. So again, this is a massive problem. The organ shortage continues with a growing gap between supply and demand. And we've seen here that new hep C infections shown in the upper panel have increased dramatically, again, because of the injection drug use epidemic, and correspondingly an increase in opioid use and deaths due to opioid deaths, shown here on the upper panel. HCV positive donors with overdose deaths shown in the uppermost graph have shown a dramatic increase compared to other forms of death. And those increased risk donors, again, have increased dramatically in the United States as a result of this trend line. So coupled with the knowledge that DAA regimens are uniformly successful in patients who have undergone both liver or kidney transplantation with, again, nearly 100% rates of success, had given us the opportunity to test the concept that treating patients after receiving an HCV-infected donor organ in an uninfected recipient can be done safely and successfully, right? And so the first such study was a study of 20 patients who received kidney transplants from infected donor organs. This is called the Thinker trial, and they received, in this case, this was restricted to gene type 1 patients who got grazoprevir and albusphere for 12 weeks, with ribavirin added for an extra 4 weeks if they had gene type 1A with resistance substitutions. But using this strategy, it was a reactive approach. So if viremia occurred, they were treated, and 100% of these patients achieved a sustained response. A quarter of these patients actually experienced delayed graft function. We don't believe that was causally related to Hep C, but that still needs to be parsed out. And they had excellent allograft function at the end of the day. We've now designed a multi-center study looking at glecaprevir pibrenizumab, which can be safely administered in patients with any form of kidney dysfunction and can be done pan-genotypically. And this is going to be an 8-week regimen given preemptively on call to the operating room for these patients, and then given a follow-up period to document cure. We have tentatively slated 30 patients to be enrolled in this viremic cohort. We're nearly enrolled in this, fully enrolled in this study, and we are very excited about the prospect of demonstrating the success of this brief regimen in patients undergoing kidney transplant. I want to share with you data from heart transplantation. This is a particularly high-need area where patients are critically ill and are in need of heart transplants but don't have any donors forthcoming. We applied GP here for 8 weeks in this context, just at our center alone. And in those who received NAT negative or RNA negative donors, we simply embarked on an observational approach where we, at any point in the follow-up period, if RNA returned positive, we then treated those patients because of the very low frequency of viremia in these patients, predicted to be 1% or less. So these are the data which we just published recently in the Lancet Gastro and Hep of 25 such patients, 20 of whom were NAT positive, 5 of whom were NAT negative. And the bottom line is that these patients were treated again preemptively, and you can see here that their frequency, their time to unquantifiable or undetectable viral load was very brief. They became virus negative within days, and these patients, to a person, each experienced sustained response and had excellent allograft outcomes, as good if not better than their HCV negative counterparts. And what was dramatic was that the wait time for these patients was dramatically reduced compared to those patients who received HCV negative donors. 20 days for those patients in the HCV protocol compared to 113 days for patients in the HCV negative group. And these were patients who were on LVADs, who were in the ICU for days, weeks, and months, and then heard about HCV positive donors within days. So this really represented a dramatic effect. For liver transplants, this is a slightly different story because the liver is the reservoir infection. So Hep C is not coming along for the ride, but it's in the donor liver, right? And so in this case, we're not preempting them, but we're actually treating those donor livers, right? So in this strategy, we would immediately treat as soon as feasible, but we're not really preempting them. And so we developed a protocol at our center, again, about 1.5 years ago, where we could either offer soft-vel, which is safe in hepatic impairment, but not so much in renal impairment, or GP, which is the inverse, safe in renal impairment, less so in hepatic impairment. With early initiation of DAA therapy, because the concern for reactive therapy is honestly the risk of fibrosing cholestatic hepatitis in these patients. And so this is the strategy, offering 12 weeks of therapy in the immediate treatment for NAT-positive donors, and then an observational approach to those patients who receive NAT-negative donors, with the idea that about 15 or 16% of those patients will become viremic based on current literature. And so this is our experience to date on 14 such patients, 3 of whom were, actually 4 of whom were NAT-negative, but one of the NAT-negatives, the last patient here, became quickly viremic post-transplant, and so they are now on treatment. But thus far, of the 13 patients who we have follow-up for, there has been a sustained response in every one of them. And moreover, if you look at liver function, in those patients at the time of the operation, there were elevated bilirubins and INRs, but at 30 days into treatment, these patients had now nicely improved on all these parameters, their enzymes, their bilirubins, their INRs, and then remained so 3 months later. So this is a safe regimen that's feasible and efficacious, not only preemptively in the case of hearts, kidneys, and lungs, but also in an immediate treatment approach in the case of livers. And we've thus far now treated over 75 organs at our institution with successful sustained response in every one of them thus far who's gotten into a long enough follow-up period. Well tolerated even in those patients with extensive hepatic dysfunction going into the operating room. And certainly we have already seen that it increases our donor pool dramatically and may reduce wait times significantly. A further study, I think, is needed to define optimal regimens and timing and duration, but I think it can be justified now as a standard practice. So to summarize, I hope I share with you that sustained response with DAAs has already produced unprecedented clinical benefit. The challenges now remain really implementation, elimination, and vaccine development. The residual risk for HCC appears to persist. It's reduced significantly, but appears to persist, and is driven probably by genetic, epigenetic, and transcriptional changes. And these signatures, transcriptional signatures, can be predictive of future HCC risk. There's a cooperativity, again, between high-risk signatures and the risk for HCC in the sense that the presence of cofactors like alcohol and fatty liver and Hep B and iron should intensify our vigilance even further in these patients. And stratification and chemoprevention for high-risk patients may become possible based on the tools that we have in hand. Surveillance must continue in these F3 to 4 patients even as the fibrosis may regress. And the safe to stop surveillance time point still remains unknown, so we must continue in that practice, at least for the foreseeable future. And then the use of HCV-infected donor organs for transplantation appears to be not only safe and feasible, but efficacious using DAA-based regimens. So I want to close and thank all those who worked to generate much of this data, as well as including our collaborator at KMU, Professor Yu, and to thank our funding agencies. And again, thank you for your attention.
Thank you. Thank you very much, Ray, for share us such updated cutting-edge data for the HCV management. So on behalf of the organizing committee, I would like to present the plaque to appreciate your contribution.
各位医师好，我们的便当会直接送到你们的座位上，谢谢。